So our next speaker is Anton Volosovets, speaking on mental health, emergency psychological care, and prevention of PTSD.
Thank you for being here for Ukraine, and thank you for being with us in these dire times. I would like to speak with you about the PTSD. Of course, today we have heard a lot about this, and I will be brief about the main pathophysiology and main aspects of this, I should say, catastrophic state of the human psychology, human cycle. Therefore, it is a result of an action of a stimulus that has extraordinary strength and also has a deep impact and deep impairment of the person's boundaries. Sometimes it's even physical boundaries. But we speak not about a trauma itself like physical element, we're speaking about the psychological trauma, emotional and mental aspects of it. Usually this factor which appears before the person is sudden. It's extremely strong. It is unbeatable. And therefore the person which feels this helplessness, the person feels fear, the person feels despair, the person feels horror. And then these feelings continue to preserve, continue to exist, and continue to grow in the psyche of the people. How does trauma appear? We know that the low-strength stimuli is not so important for us, therefore we appear to feel the stimuli as an experience. But the strong stimuli, big stimuli, which is traumatizing our psyche, remains as a scar on our psyche, flaming scar, inflamed scar, which is continue to evolve, continue to influence the psychology of a person, behavior of a person. And if it is a childhood trauma, the personality of a person develops around this scar. The person becomes traumatized. How do we know about the mechanism of a trauma? We know that we have three main elements of our nervous system. It is a cerebral cortex, it is a limbic system, and it's a brainstem. And if we are speaking about an influence of those structures, we know that the cerebral cortex is the most young, most developed, most complex element of our nervous system. And limbic system is more ancient, more instinctive, more aggressive, more survivable. Brainstem is our vegetative functions, which allows us to breathe, allow us to have heartbeat, allow us to control our vital function. Interesting is that our most ancient, most primitive structures are controlled by most complex and most young functions and most complex structures. Therefore, the brain cortex is young structure, but it is the one who controls our ancient and more primitive structures as a limbic system and brainstem. And a bit later I will explain why it is important to know this. And we know that the different mechanisms, different triggers which could influence on our borders may imply trauma. For example, cognitive dissonance, great cognitive dissonance, may imply heavy impairment of psychological or mental borders. Emotional, severing of emotional ties leads to usually decreasing or impairment of emotional boundaries. And per se, physiological boundaries are easily impaired by different traumas and interventions. And we saw that usually cognitive factor influences on the cognitive sphere, on the cognitive boundaries. Mental on mental, emotional on emotional, physical on physical. But truth is that every enormous factor, it doesn't matter, emotional, cognitive, or even physiological factor, leads to impairment of all boundaries together, and mental, and emotional, and physiological. And how does it influences on our brain? It has a great influence, which leads, first of all, to cognitive decline. Our brain thinks that when we appear in the situation when our life is under constant and great threat, We should not think about it. We should react. Therefore, our cortex goes down and our limbic system raises. It's like an unleashed tiger, which the main mission of which is survival. Therefore, our emotional part goes up, our cognitive part goes down. Therefore, we could not think properly when we have trauma or we have a great emotional distress. Plus, as the answer of the emotional distress, our physiological part, like our brainstem, activates our vegetative system. First of all, it is sympathoadrenal activity. And mental responses, like I said before, it is a breakdown. It is usually an ability to concentrate, an ability to learn, an ability to analyze information properly. Emotional response is usually high. It is hatred, it is fear, it is despair, it is crying. It is different elements of emotional liabilities which could not be controlled by a person, and it is not their fault. Also, physical responses, usually it is a prominent manifestation of an activity of sympathoadrenal system, like heartbeat, like swelling, like pale skin, for example, etc., etc. And if we speak about the physiology of stress, we know that when the stress appears, when the threat appears, we activate sympathoadrenal activity, and then we solve the problem, or as our brain thinks that we should solve it by fight or fly or freeze, yes, elements, and then we recuperate. Then we restore our resources, and then we activate, yes, vagoinsular elements, parasympathetic system. It's okay, but what happens when the stress is not solved, is not disappeared, is not conquered? Then we have exhaustion, because we continuously exist in the state of constant danger, constant threat for life. And this threat is continuous, this threat exists over your head, exists over your life. And you could not recuperate from this because you should constantly be in the state of awareness, state of battle readiness. And your sympathoadrenal system will exhaust, squish your brain from all resources existed. We know that we have three main stages of stress. It's mobilization, adaptation, and exhaustion. And like I said before, the persons with chronic stress usually exist in the stage of exhaustion. And how do we compare the patients with PTSD and patients with chronic stress? Because PTSD create chronic stress inside the mind of a person. Because we should not have any threat in our surroundings. We have this threat inside our mind. And therefore, this threat leads a person to create the state of constant awareness, constant exhaustion, and constant battle readiness. Interesting is that PTSD usually do not form quickly. We have usually 30 days to form this element of pathological reaction on this negative or over-exaggerated trigger. And more than 30% of the patients will have PTSD after 30 days after the onset of the trauma. What factors could save you? What factors could give you resilience? Could give you a chance do not develop PTSD. First of all, it's physiological factors. How fit you are, how strong you are, how your body tells your limbic system that you are strong, therefore you do not feel the despair. Situation factors. Did you used to it? Did this trigger is big for you, important for you, or you are just used for it, for example, like we used for the missile attacks? Relationship. If the persons who you value most around you, if they support you, if your pride is around you, we are speaking now about with the language of limbic system, then they support you, then they say you are not worthless. And then your limbic system becomes calm. And of course, it's a level of personal development. It means the level of the complexity of your brain cortex. Higher intelligence, higher education, high concentration on intellectual activities will give you strong cortex and control over your emotions. And of course, personal external resources. If you are in cold, if you are in a hunger, if you are thirsty, PTSD will appear much more frequently. I will not discuss and put these elements. It's a very simple questionnaire about quick diagnostic of an PTSD at the person, the first elements of it. I will not stop on those, but you may make a photo and you may ask those questions yourself. How do we help? Of course, first of all, we must know how to help ourselves. And first of all, our mental self-care should be concentrated on increasing of our cortical activity. Usually it is some forced intellectual activity like naming the colors, like concentrating on the texture, like concentrating on different elements of surroundings, which allows us to think and activate the centers of the cortex, which are not connected with the memories of the trauma. This allows us to change our focus of attention and lessen the influence of a traumatic agent. Of course, the very effective, very convenient thing to do is the breathing techniques. Of course, there are a lot of them. The most convenient one, most used one, is so-called square breathing. Like when you breathe for count of 4, then you hold your breath for count of 4, then you breathe out slowly for a count of 4, and then you again hold your breath for 4 seconds. And then you repeat this cycle one by one until you get calmed. Emotional self-stabilization. This element needs us to change the pace, needs us to calm yourself, needs us to chain our inner tiger, to calm it and tell our inner tiger that we are in a safe place. Our brain does not make a difference between imaginal or real reality around us. Therefore, if you close your eyes and will tell yourself that you are in a safe place, the most of the techniques of emotional self-stabilization are visualizations. Visualizations of safe elements, safe surroundings, safe persons around you, which calms your limbic system, which transforms its reaction from aggressive to calm one. Physical self-care. Of course, this is mostly we work here with muscle contractions. We work here with feeling of derealization. We work here with elements of disconnection from your body. We should say this poetically a bit, yes? And therefore, it is the techniques of the groundings, it's the techniques of self-sensory techniques, which allow us to return our understanding, our feeling of our own body, and therefore to change, of course, again change the focus of our attention from the traumatic agent to our own body. What could increase the influence of a PTSD? What could deepen your trauma? What could make the scar deeper? First of all, it's self-criticism. You're starting to call yourself weak like your limbic system do. It is not true. Keep your feelings to yourself, containing them. Of course, it will poison you from inside. You should share those feelings. Expecting things to go back to normal immediately. Of course, it won't be so, but the broken hopes will deepen your scar. Staying away from other people. Of course, when we are traumatized, we are trying to isolate ourselves from the influence of the others, but it's a failing strategy. Because we need approval of our pride, approval of our surroundings to help our mentality to be stable. Plus, drinking, smoking, using different stimulators, of course, it is not approved and it only deepens your emotions. Unfortunately, it will not bring you calmness, it will only unleash your tiger again with inhibiting the influence of your cortex. And of course, exhaustion, for example, with the work, when you're trying to change your focus from the trauma to your activities different, and you will only bring your brain to additional exhaustion and only bring your cortex to the lost control over your limbic system. First aid. What you should do or what can you do for the other person? Usually we speak about 6 elements of the psychological first aid approach. First of all, you must approach safely to the person. Then you must support him or her and allow them to change their focus from thinking about the trauma on thinking about different high cognitive skills. Give them advice, support them, care for them, and then when the crisis is over, you should pass this patient over to psychological care, specialized psychological care, for example, etc., to the specialist who will care about him or her further. So, like we said before, it should be non-intrusive provision of practical help and support in the first 72 hours after the traumatic event. First of all, we need to assess needs of a person. For example, if it's cold or if the person is hungry, we should satiate those needs. Listening to the people without forcing them to talk. So you should not, trying to grab this information from their souls, from the psycho, because it only leads to deepen the trauma and deepen the scars of the traumatic agent. Helping people to get information and make connections, supporting, do not judging, and protecting people from further harm. All of this is included in psychological first aid. What is not included? Psychological first aid is not something that only specialists could do. It is a common knowledge, and it is not a professional psychiatric or therapeutic concealing. It is common knowledge that everyone should know and everyone should practice, for example, in our warring country, because traumatic agents happens every day. Missiles falling, our dear ones dying, all of us should know this. So, what integration algorithms of the shock trauma, what should we do to help? First of all, it's a physical security, like I said before, then acceptance and support to calm down limbic system, stabilization of cognitive, emotional, and physical state, like we said before. It was self-care, now we speak about, the care for the others. Instilling hope. Hope, especially approved hope, is a very powerful mechanism. Powerful mechanism to resurrect the soul of a person which is traumatized. And of course, it's planning for the future to improve and to approve this hope for the person. Cognitive stabilization. Of course, I will not discuss every point of this slide. I will say only that we should change the focus of a person from emotional element, from trauma agents, on some cognitive activity, on some cognitive elements and logical analysis on information, of surroundings, of facts, of different things. And when the cortex even forcefully starts to grow more stronger, therefore we achieve possibility to inhibit our limbic system, to calm down and think about situation logically. Emotional stabilization. Calm your target down. Change emotional elements. Do not force them, do not push them, do not make the pain more strong, but change emotional activity. Calm the person. Physical stabilization. Physical stabilization usually includes vital needs, vital necessities, and you should not overcome, and you should not dominate, you should not judge, and you should not penetrate or impair physical boundaries. So touching, softening, speaking, level of speaking, all those different elements should be done very softly, very carefully, and only after the approval of a person. And of course, medication therapy. There is a wide approach to trying to, when the other medical workers, for example, trying to help the patients, it starts from, start from different therapeutic approaches, from light therapy to the neuroleptics or even antidepressants. And when we are trying to make a decision about the strong therapy, about the strong influence on the neurophysiology, about the starting to use antidepressants, first of all, we do so if the patient is unwilling to participate in trauma-focused psychotherapy, if the patient is not stable enough for this psychotherapy, if he is not received sufficiently good results after this therapy, and if the patient has strong, complex PTSD with a large number of psychological symptoms. Then we decide to make an intervention with strong medical drugs. Dear colleagues, thank you very much. I would appreciate greatly if this knowledge won't be of use for you ever, but unfortunately they are. Therefore, keep calm, stay safe, and let's go together for the victory. Slava Ukraini! Please, any questions? Thank you.
Thank you very much for the presentation. A very nice synopsis of acute trauma processing. Is this currently available at the first-line hospitals near the front, this process?
I must admit that thank you for an interesting question. And of course, for now, we have psychological trainings like MHGAP, for example, for the first line of medical care. We have specialized trainings for emergency psychological care, like we said before. It is developing. It is developing, it is implementing, and I have a great hope that every emergency center, every first like polyclinical center will be knowledgeable about these elements. We're trying to educate as much people as we can. For example, this training was created first of all for the warriors, for the soldiers at the beginning. Now we are widening this on our healthcare system.
So I'm assuming that the primary caregivers, the nurses, the surgeons, these are the people who will be giving this, because I assume you don't have enough mental health professionals to sit at the front lines. Or do you have somebody embedded in the front lines?
I think it's mostly about emergency care workers. Emergency care, like situation on the site of a disaster, for example, yes, on the site of the mass casualty, yes, situation. And only then it's like first approach. And only then when the person receives or does not receive proper this help, this patient go to the specified medical help for the specified psychiatric help, for example, in hospital, or he may or she may receive this help from her family doctor, because family doctors also have now this training. MHGAP program is widely spread throughout our first line of medical help. Therefore, I hope that no one will stay without help.